Welcome friends, let's discuss INI-CET Ortho recall questions, myself Dr. Kathir Stalin. The first question we are going to discuss is something related to port spine. The most common pattern of involvement in port spine is the options given were paradiscal, central, anterior, posterior. Before answering this question, we should know what is paradiscal, what is central, what is anterior, and what is posterior. Look into the above image. You can see paradiscal, the most common. This is what called as paradiscal. The word para means adjacent, next to, and the word discal indicates disc. So the word paradiscal means this, right? The word central is the central of the vertebral body. The word anterior indicates anterior to the vertebral body, and the word posterior indicates the spinous process and all the posterior elements of the vertebra. Among this, which is the most common, paradiscal is the most common type. Why? You all know the spread of infection to vertebral body is through hematogenous route, right? It is hematogenous route. And how the vascular anatomy of vertebra is distributed. You see, a blood vessel comes like that and supplies two adjacent vertebra at the same time. Whenever there is an infection going like that, then it equally goes to both the vertebra, and that is the reason why paradiscal is most common. Clear? So paradiscal is the most common and posterior element involvement is least common, which means like the spinous process involvement, facet joint involvement is the least common. Let's quickly go to another question tested on the same topic, port spine. All of the following are indication of surgery in a port spine patient except look into the option. Cold abscess without neurological complication. The question says when you will not operate on this patient, right? Do you really want to operate on a patient who is not having any neurological complication? So I'll not do that. Anyway, let's see the other options. Doubtful diagnosis. See, whenever you are not certain about the diagnosis, when you are not sure about the diagnosis, then you need a tissue to diagnose, right? The gold standard investigation or the gold standard way to diagnose tuberculosis is culture, and you need tissue. So in case of doubtful diagnosis, you can do operative management. Drug resistant TB, you tried with every drug and nothing seems to be helpful, and it is a multi-drug resistant or extended drug resistant. So in case of a drug resistant TB, you can do operative management, and patient is presenting to you with a cauda equina syndrome. Cauda equina syndrome is a surgical emergency, and you have to put the patient in your table to operate and to release the pressure there, right? So it is an operative management. So of all the four options, I would say cold abscess without a neurological complication, I'll try to manage it as non-operative. Non-operative. So what are all the operative indications and non-operative indications for tuberculosis spine? No neurological deficit, you can try to manage with non-operative. But what are all the operative indications? Whenever there is a neurological deficit, when the patient is having instability, spinal instability, or the deformity is so high, the kyphosis needs to be corrected. In that case, you need a surgery. Or the person is having a large caseation and which is preventing the access by any antibiotics, then in that case, you may need to release or debulk the caseation. And failure of non-operative treatment or medical treatment after 3 to 6 months, and diagnosis is uncertain and panvertebral lesion. All these are operative indications. The next question related to the spine surgery was tested again in INI-CET past years. In spine fusion surgery, the screws are fixed to which part of the vertebra? Look, before going through these options, you should know what are all the parts of vertebra, right? Spinous process. What is spinous process? This is the spinous process. Do you think if someone is trying to put a screw like that, no man, that's going to go through the vertebral canal and that's going to damage the all the neural structure inside. I'm not going to do that, right? And facet joint, what is facet joint? That is facet joint. So if you are trying to put a screw like that, which structure are you stabilizing? The only bone that you will be catching in the trajectory of the screw would be some bone here and some bone there. And which structure are you trying to really stabilize by putting a screw in that? So facet joint cannot be the answer. Spinous process cannot be the answer. What is lamina and what is pedicle? You should know what is the difference between a lamina and pedicle. In this picture, you can see this structure. This is lamina, okay? in olden days, we always do like laminectomy, and things like that to debulk the pressure at that side, in case of a disc prolapse and things like that. But if you are trying to put a screw in that this way, that is not going to hold any part, and it's also potentially dangerous because it will damage the nerves. And if you're trying to put a screw like that as well, this part is not big enough to hold a screw, right? So which is the best part to put a screw? The best part to put a screw and the best direction on the best trajectory would be this, right? Would be this, right? So what is that part called as? That part is called as pedicle. That part is called as pedicle. So do you remember when we were discussing something about the winking owl appearance in a metastatic spine? The vertebra would be like that, and there would be two eye, and one eye would be missing in case of metastasis and things. Do you remember? That two eye is actually indicating the pedicle of the vertebra. That indicates the pedicle of the vertebra. So where would you put the screw? In the pedicle. In the pedicle. Across the pedicle. It should go through the pedicle and fix into the vertebral body, and that is the best trajectory in order to stabilize the spine. Let's look into the next question. A 60-year-old patient present with limping gait and left hip pain. What is the likely diagnosis? See, this might be a tough question in some case, but understand the question says a 60-year-old patient, right? 60-year ankylosing spondylitis is usually a middle-aged disease. And rheumatoid arthritis, usually a female disease and again a middle-aged disease. It could be a person who is limping gait, could be a rheumatoid, could be an ankylosing spondylitis, could be a tuberculosis, right? Tuberculosis of hip. So the patient with the tuberculosis of hip might have some infectious symptoms, right? Symptoms of infection may be there, and all other symptoms of tuberculosis like weight loss, loss of appetite and things. And usually tuberculosis affect the spine first and then the hip. So the patient may have some spine related symptoms. You may expect some kind of cue to indicate that it is a tuberculosis from the question, but nothing of that sort was present in this question. In that case, I'm thinking more of an avascular necrosis. Now, let me look into the x-ray to make a diagnosis. So looking into the x-ray, I see lot of sclerotic pattern, right? Be it a tuberculosis or a rheumatoid arthritis, most often tuberculosis and rheumatoid arthritis involve lot of blood flow into the bone, and the person will have more of osteopenia. But in this case, there is no osteopenia, rather there is severe osteosclerosis. So what is the sclerosis indicating? The sclerosed bone indicates a dead bone, right? Dead bone. Okay, dead bone looks white. Looks white in x-ray. Looks white in x-ray. So what does this these whitey patches in the femoral head is indicating? They indicates a dead bone, and that further supports my diagnosis of avascular necrosis as an answer for this question. So the safer option in for this question would be avascular necrosis. So coming on to TB hip, since the question asks something related to TB hip, it would be prudent for you to know the stages of the TB hip. First, it presents like a synovitis. That's what I was telling. It involves it induces a lot of inflammation and attracts a lot of blood flow into the synovium, and the synovium would look more inflamed, and there would be a massive osteopenia. And then it will induce an early arthritis, and then a late arthritis, and advanced arthritis, right? So that's how. But in X-ray, what are all the potential appearances that it can have or it can show? See, a TB hip can be a stable hip form or an unstable hip form. It could look normal, it could look atrophic, and it could look perthes, right? So all these are stable hip types, and there are something called unstable hip form. For example, if the damage is severe and it can present like a traveling acetabulum, the hip may be go for dislocation, or protrusio acetabuli, or mortar and pestle appearance. All these are unstable hip type, unstable TB hip types. So these are all the potential appearances that I would be expecting in a TB hip than a typical avascular pattern. Sometimes a pertitoid type of tuberculosis hip can look like an avascular necrosis, and of course, a TB can also be a potential cause for avascular necrosis as well. So it's a bit confusing, but still, for the above question, I would go for avascular necrosis as a better option than to think deep and answering tuberculosis. Rheumatoid hip, one of the classical question which can be tested related to rheumatoid hip is protrusio acetabuli. So you see this acetabulum is protruding into the pelvis. So this we call as protrusio acetabuli. Protrusio acetabuli or otopelvis. See, it breaches the collar line. It breaches the collar line, right? So the protrusio acetabuli, there are heaps of causes for protrusio acetabuli. One of the commonest cause is rheumatoid arthritis. So protrusio acetabuli can be a potential question maybe in few years. And an ankylosing spondylitic hip. Remember, ankylosing spondylitis hip, of course, it can affect hip joint. I agree. The earliest complication or the earliest joint to be involved in ankylosing spondylitis is sacroiliac joint. And then it is an ascending spondylosis, which means from the sacroiliac joint, it just goes up, right? Then lumbar, then thoracic, right? So that's how it goes. And it can cause a hip joint arthritis as well. So remember, hip joint involvement is not common with ankylosing spondylitis. Rather, sacroiliac joint is the earliest joint to be involved. It's the earliest joint to be involved. But if at all hips are getting involved, there is a high chance for it to get involved as well in late stage of the disease. Look, this is again an inflammatory arthritis, so the patient will have a lot of osteopenia, and and you will always see a sacroiliac changes, the sacroiliitis associated with the hip joint pathology. And you can see there is in late stage, if left untreated, the hip joint can go for complete ankylosis, as in this case. Right? So it again induces a lot of inflammation into the synovium, and then osteopenia and things like that, as I was explaining. So these are all the potential x-rays that you might need to have a look in order to prepare for subsequent exams, guys. The next question again related to the hip, but this question is from trauma. A 22-year-old female patient present with a history of road traffic accident. His leg is in abduction and external rotation, maybe something like this, right? Female, so her leg. Okay. Her leg is in abduction and external rotation. What could be the cause? See, guys, from this picture, right? Well, none of this picture was given in examination. If at all, maybe they could have given this picture. But just for the teaching sake, I added a few more pictures. See, whenever there is a posterior dislocation, which is the most common type of hip dislocation, the patient would present with flexion, adduction, and internal rotation, right? Because that's the exact mechanism by which the posterior dislocation happened: flexion, adduction, and internal rotation. But how a patient with anterior dislocation of hip would present, that is very rare. It is very rare type of hip dislocation. Right? Because it needs a tremendous force to dislocate a hip anteriorly, right? And the patient would present with abduction and external rotation, as in this picture. Can you see it is abducted and externally rotated? So that's how an anterior dislocation patient would present. Then what about the intertrochanteric fracture and fractured neck or femur? See this picture, guys. Look into that picture. Whenever there is an intertrochanteric fracture or fractured neck or femur, the limb would look more shortened, right? There would be a shortening plus external rotation deformity, then more of an abduction. Of course, the patient can have some a minimal amount of abduction, but it is not as fixed as in case of an anterior dislocation of the hip. So, although intertrochanteric and fractured neck of femur can have some amount of abduction and external rotation, shortening and a massive external rotation is a classical feature of an intertrochanteric or a fractured neck of femur, as explained in this picture, than a pure fixed abduction and external rotation deformity, which is a feature of an anterior dislocation of the hip. The next question is again from hip dislocation. From the previous question, you must know now dislocation posterior dislocation is more common than anterior dislocation in hip, right? Which is exactly opposite to shoulder, because in shoulder, anterior dislocation is more common than posterior. Anterior dislocation is more common than posterior. So let's approach this question. Which of the following is false regarding the hip dislocation? Let me read the options from the bottom. Posterior dislocation is more common than anterior. It is definitely a true statement. In hip, posterior dislocation is more common than anterior. It is definitely a true statement. Let's read the first option. Posterior dislocation of the hip has flexion and adduction. From the previous question discussion, we clearly know, yes, in case of posterior dislocation, there is flexion, adduction, deformity, flexion, adduction, and internal rotation deformity. And in anterior dislocation, it is abduction and external rotation deformity. So this statement is true as well. But the next two options, this is where the confusion is, right? Vascular injury is more common in anterior, or nerve injury more common in anterior? To be honest with you, both vascular and neurological complication with an anterior dislocation is very, very rare. It's very, very rare, right? But if at all the question asks which is more common, vascular injury or nerve injury, then we can say a vessel injury is slightly more common than a nerve injury. So in that case, this goes true and that goes false. So to this question, I would say C as the answer. But if this is a question to which multiple options can be an answer, then I will definitely say even B and C. Both are uncommon, guys. Both are uncommon. The next question is again from the hip dislocation. So this question is about a 15-year-old boy who was brought to ER following a motor vehicle collision, complaining of pain over the hip. The X-ray is given below. What is the next step of management? Come on, guys, what type of dislocation is this? So from the X-ray, it is two-dimensional. You can't say whether it is anterior type or posterior type, but you know posterior dislocation is more common than anterior. In my opinion, you can still say this is posterior dislocation because you see the adduction deformity, the hip is adducted, and I told when the hip is flexed and adducted, the dislocation is mostly posterior. So, given the finding of adduction in this X-ray, I would say this is a posterior dislocation. And the question asks, what is the next step of management? Any dislocation. Remember, even fracture is not emergency unless it is a big open fracture or it is associated with a complication. Fracture is not an emergency, but dislocation is an emergency. So the first thing in case of any dislocation is to document the dislocation, and then close reduction and assessment of hip stability is the first thing that you are going to do. CT pelvis with 3D reconstruction, probably after reduction, you can put the patient in CT and look for any small fragments or pieces inside the joint, or you can look for an associated, so you can look for fragments, you can look for associated femur fracture, or when you are trying to reduce, you could have fractured the femur, or an associated acetabular fracture. So you may need a CT pelvis with 3D reconstruction after reduction. And high weight skeletal traction, that is a reduction method, but when you can do that with an Alice or Bigelow, you really don't need the high weight skeletal traction method as a first way or the next best step of management in case of a hip dislocation. Open reduction and reconstruction of posterior pillar of acetabulum, only in case of an acetabulum fracture you are going to do that, right? So you are not going to do this as a first step. You are neither going to do that as a first step. Only after reduction you may need a CT pelvis to assess the fragment femur fracture or acetabular fracture. So the correct answer for this question is close reduction and assessment of hip stability. The next question. This question asks the correct sequence of Thomas test, very commonly tested topic for orthopedic registrars. So it is better you guys know that, okay? And the first option they have given is a squaring of pelvis. Come on, guys, squaring of pelvis. Why you need to square the pelvis? Squaring of pelvis is before you trying to assess an abduction or adduction deformity, adduction or abduction, adduction or abduction deformity, you need to square the pelvis. But a fixed flexion deformity is no way going to be altered because of you trying to square the pelvis. So it is very clear squaring of pelvis is not going to be in the sequence. So that now reduces my correct answer to be within C or D. Thomas test is assessing the increased lumbar lordosis, right? Because increased lumbar lordosis happens as a compensatory mechanism for fixed flexion deformity. Increased lumbar lordosis happens as a compensatory mechanism for a fixed flexion deformity. So you need to look for the exaggerated lumbar lordosis, and then you got to flex the hip, and once you flex the hip, then you need to overcorrection of the normal side has to be kept in mind, and then you should go ensure the ischial tuberosity touches the ground, and then you measure the actual flexion deformity. So the correct sequence is 3 2 6 5 4. Which of the following zones heal faster in meniscal tear repair? See, this question asks about the vascular anatomy of the meniscus. You know, meniscus is nearly an avascular structure. Only few parts of the meniscus is having a vascularity. So the vascularity comes from outside. So if this is in the first picture, see, if this is the meniscus, the vascularity comes from outside, and you see the peripheral most part is having lots of blood flow than the central most part. So they classified the zones of meniscus as all red zone, that is RR zone, red zone, right? And the second zone as some red, some white. So RW zone, red white zone, and the third zone is WW zone, which is all white zone. Okay? So zone 1, zone 2, zone 3. If you know this vascular anatomy, you can clearly answer this question. What do you think? Which tear would heal? If it is a peripheral tear, if you are trying to do a suture repair, because of the vascular anatomy and the vascular supply, there is a high possibility for a red zone injury to heal than a white zone, because it is already not having any vessel, and even if you are going to suture, there is no growth factor coming into the repair, and the possibility of it healing is uncommon. So whenever there is a peripheral tear, that is a red zone injury in a meniscus, you try to repair because there is a high chance for it to heal. But if at all there is a central tear, you better debride. Because the possibility or the chance for it to heal is very less. So red zone is having a higher chance to heal. So that is the correct answer. White zone, gray zone, red, white zone. No. They are having less chance for healing with a tear repair. Now, this question is about shoulder. Anterior dislocation of shoulder is likely to result in damage of which of the following nerve? You know, the only nerve which comes like that and then encircles the humerus like that is axillary nerve. And whenever there is a dislocation happening, axillary nerve is stretched. So axillary nerve damage is most common, and the most common type of nerve injury in that case is neuropraxia. Okay, suprascapular nerve goes there, right, to supply the supraspinatus and then go through the spinoglenoid notch and then comes down there, and it supplies the infraspinatus at the back. Okay, at the back and not in the front. Okay, so axillary nerve injury is more common than any other nerve listed in this option. A female with a history of fall few months back present with the deformity shown in the image, probing into the history reveals that it is managed with a traditional treatment. So it shows it is a malunited fracture, right? Traditional treatment, and female patient few months back, it's a malunited fracture present with the deformity shown in the image. So what is this deformity? So this deformity is called as dinner fork deformity. You all know that, right? So it's a Dinner-Folk deformity. In case of Dinner-Folk deformity, how you are going to manage this? This deformity is likely due to what fracture? Dinner-Folk deformity is due to Colles fracture. The question is about Abraham Colles fracture. What type of fracture is Abraham Colles? That's the question, right? Whether it is an intra-articular fracture or an extra-articular fracture. It is definitely not a boxer fracture. It is not a Barton fracture. So whether it is intra-articular or extra-articular, let's discuss that. So Colles fracture, you see, this is the distal radius, guys. This is the distal radius, right? And there is the carpal bone, and that's the wrist joint, right? So the fracture line is totally away from the joint. That's the joint, right? So, and the fracture line no way touches the joint. So I should call this fracture line as extra-articular. Extra-articular. Same as Smith fracture. Smith fracture is again an extra-articular fracture. But you see, in Colles fracture, the distal fragment has moved dorsally, while in Smith fracture, the distal fragment has moved volarly or to the palmar surface, right? Right. So the difference between a Colles and Smith fracture is the displacement of the distal fragment, whether it moves dorsal Colles or volar Smith. And what is Barton fracture? Barton fracture is an intra-articular fracture because you see the fracture line in the Barton fracture. The line goes into the joint, right? That's the wrist joint there. So the line goes into the joint. So that's a Barton fracture. When the Barton fracture chips out the dorsal fragment, then chips out with the dorsal fragment, then it is dorsal Barton. If the same intra-articular fracture with a olar chip, then I would call that as a olar Barton, right? So a dorsal Barton and olar Barton. What is boxer fracture? Boxer fracture is basically not a distal radius fracture. Boxer fracture is actually a fifth metacarpal neck fracture. Fifth metacarpal neck fracture. Is there anything related to any fracture related to boxing can happen in the distal radius? Yes, we call that as a die punch fracture. Die punch fracture, right? Die punch fracture is a lunate fossa fracture of distal radius. Lunate fossa, not lunate bone. The lunate would try to impact into the lunate fossa of the distal radius. So it affects the lunate fossa. It affects the lunate fossa of distal radius. So for this question, I would say the correct answer is extra-articular fracture of the wrist. So the correct answer is extra-articular fracture of the wrist. An old lady slipped and fell at home. She was diagnosed with a Colles fracture and the management with the POP cast. What is the correct sequence of reduction? Okay, this is now an important question. See, ever since 2015, if I'm not wrong, AIMS was really interested in the reduction of Colles. But they were asking in a different way, okay? They asked the questions like, what is a deformity type in a distal radius fracture? And you know, the mnemonic for the deformity is LITS, right? Lateral tilt and displacement. I for impaction. D for dorsal tilt or displacement. I was telling you what is dorsal tilt and displacement. Displacement. And yes for supination. So if this is the deformity that is going to happen with the Colles, what you are going to do to correct this deformity? Now you should make sure you are receiving the hand in pronation. Can you see? The arm is pronated in order to correct the supination. And then they are trying to pull. Yes, they are trying to pull the fragment in order to correct the impaction. So traction. So once you corrected the impaction, then you got to correct the other deformity, which is the next deformity you want to correct, the dorsal displacement and the dorsal tilt. So how you are going to do that? By doing a palmar flexion. So do the palmar flexion and correct the dorsal tilt and then correct the lateral tilt and displacement with the ulnar deviation, right? So the correct sequence in this case would be attraction, palmar flexion, ulnar deviation, and put a POP in the corrected position. So that's how you're going to do it, and rest of the options are wrong. So again, a question from Colles fracture, which says an 8 month ago the patient had a Colles fracture. History of Colles fracture 8 months ago. Comes to orthopedic department. Her T score is minus 2.5. So although this question starts as a Colles fracture, this is actually testing your knowledge about osteoporosis. So 60-year-old women, so postmenopausal could be, she attained menopause. See, it's a postmenopausal woman with a T score of minus 2.5. So she is an osteoporotic, postmenopausal osteoporotic woman, right? She is currently asymptomatic. What treatment will you give? I don't want another osteoporotic fracture. In that case, the best management to start with, the initial best treatment for any osteoporosis would be a bisphosphonate. So the answer is alendronate, alendronate, alendronate. But before starting alendronate, I should make sure the person's calcium and vitamin D is normal, and also I should make sure the patient renal function test is normal, right? So the management is alendronate, but I would definitely investigate the patient for RFD and calcium and vitamin D as well, right? So that should be your way of approaching the question. Hormone replacement therapy, of course, previously there was some concerns where in a postmenopausal woman you should start with an hormone replacement therapy, and then if it's not working or if the patient is developing complication, then you can go for bisphosphonates. But in case of senile osteoporosis, you can straight away start with bisphosphonates. But nowadays I think the first line of management for any osteoporosis, unless it is like a pathological osteoporosis due to a metastasis, even in case of metastasis, I would say like you cannot use teriparatide. So bisphosphonates is the best answer and safest answer to attempt in these kinds of questions. Fishtail deformity is seen in fracture of. The answer is distal humerus. Why? Fishtail deformity. What is fishtail deformity? Fishtail deformity is a problem at the trochlea fossa, right? So whenever there is a distal humerus fracture, the trochlea fossa goes for a dysgenesis. In a pediatric distal humerus fracture, a trochlea fossa going for the dysgenesis. And what happens is the patient develop this pattern. Isn't it not looking like a fishtail at the end because of the trochlear dysgenesis? That's why they named it as a fishtail deformity. Don't laugh at this, guys. Sometime we all name crazy things as crazy. Okay, so this is one such sign, a fishtail deformity, usually seen as a complication of a fracture supracondylar or a distal humerus fracture in which the trochlea has gone for a dysgenesis. But what are all the other signs which can be a potential question from supracondylar fracture? You see, this is a crescent sign. Crescent sign is another feature of a supracondylar fracture to indicate a varus or valgus angulation. A varus or a valgus angulation. Can you see a small crescent caused by the capitulum there and the olecranon there? So it is superimposing and creating a small crescent there. So that is a crescent sign. And the other sign that you should know is a fat pad sign. Can you see a zone of radiolucency there? So that is because of the hematoma, usually in case of a type 1 Gartland supracondylar fracture. Type 1 Gartland supracondylar fracture, you may have this fat pad sign. So all these are features of a distal end of humerus fracture. A 45-year-old patient with a tibial fracture in a cast presented to an emergency department with complaint of intense pain. The cast was removed on examination. Passive extension was painful. You see, a patient is presenting to you acute tibial fracture in a cast, intense pain, which is exaggerated with a passive extension, which means a passive stretching of the muscles causing pain, and also, but the pulses are present and there was a loss of sensation over the first web space. So there is paresthesia, there is pain, and the pain is increased with stretching. An intense pain which is increased with the stretching of muscle and not decreasing with analgesic. That is a classical explanation for the compartment syndrome. And the question is literally begging you the answer. A tibial fracture, acute, and the patient is in cast. The patient is having an intense pain and passive stretching. They are giving everything to you. The pulses were present. But remember, pulselessness is the least reliable sign. It is the least reliable sign in order to, when you're trying to manage a compartment syndrome. Okay, so the best thing that you should be doing is to measure the anterior compartment pressure, not the analgesic, because analgesic is not going to work, because it's just going to mask the pain, and in case of compartment syndrome it will fail. It can't mask the pain as well, right? So the treatment in this case is measure the anterior compartment pressure. Reapplying the cast is definitely not the way to go. It will further intensify the compartment pressure there, and the patient may even lose the limb. So definitely reapplying the cast is not an option. So duplex imaging, if you're not feeling the pulse, which means everything has already happened, all the damage that you can do to the patient has already happened, and you don't seek again more pulse with the duplex imaging. Don't try to establish that, don't try to fool yourself that it is not a compartment syndrome. Okay, so the best thing you should do is to measure the compartment pressure, and if it is more than 30, then you need to do the fasciotomy, right? So that's how you should manage this patient. Compartment syndrome is classically tested topic in any of the central board examination. Okay, so the knowledge about compartment syndrome is very commonly tested. The next question is again from compartment syndrome. This question asks about the late feature of compartment syndrome. Pallor, pain on passive stretching, these are characteristic features of compartment syndrome, and the earliest feature is pain on passive stretching. That is the earliest feature. But where is the confusion here? Is pulselessness or paralysis? To my knowledge, both are late features. Both are late features. And among this, which is the late? Let me just tell you what Berg says, okay? Whenever there is a paralysis, it indicates full recovery is no more possible. Full recovery is not possible. Is not possible. But whenever there is a pulselessness, pulselessness indicates an inevitable amputation. By reading these statements, full recovery is not possible and pulselessness can inevitably lead to amputation, I would say pulselessness would be the very late complication when compared to that of a paralysis. But some people would say, come on man, pulselessness itself is not a diagnostic criteria, right? Pallor, it is pain, paresthesia, pallor, paralysis, and a high intercompartmental pressure, right? That's how you say the diagnostic feature of a compartment syndrome. Pulselessness comes not a diagnostic feature, rather as a complication of your failed management of a compartment syndrome, right? I'm not very sure about the answer, but if the same question is asked to me, I would answer B than C. So this question asks about open fracture. Which of the following statements are true about open fracture? Tibia and phalanges are most commonly involved. True. Open fracture are very common among hand and the leg. Usually no coexisting injuries. Come on, it's usually a high energy injury and there tend to be some coexisting injuries. So that is a false statement. Compartment syndrome does not occur in open fracture. No, that is definitely a false statement. Compartment syndrome can happen in open fracture. There are heaps of paper related to this. Early debridement should be done. Of course, in any open fracture, there is possibility of infection. So early debridement should be done. So the answer is 1 and 4 are true statements. So the option is B. B is the correct answer, right? There are 4 compartments in the leg, and the superficial posterior compartment doesn't have any neurovascular structure in it, and everything was tested in the past year papers. In forearm, the flexor digitorum profundus is the most common tendon to be involved, and the most common nerve to be involved is anterior interosseous nerve, or the branch of a median nerve is the most common nerve to be involved in the forearm compartment syndrome. All these questions are classically tested, and the common cause for a forearm compartment syndrome is supracondylar fracture in pediatric population. Coming into another trauma topic, this is a sports injury question, and the question is about unhappy triad of knee. So the unhappy triad of knee or unhappy triad of Otonoha involves an anterior cruciate ligament damage, medial collateral ligament damage, and also a medial meniscus injury, right? So it's a very aggressive injury to the knee, and it damages three structure, right? So which of the following is not involved in unhappy triad? Lateral meniscus is not involved in unhappy triad, so the answer is B. The answer is B. And I hope you know what is unhappy triad of the elbow. Unhappy triad of elbow is the elbow dislocation plus coronoid fracture plus radial head fracture. So this three is called as terrible triad of elbow, and we also call this as a terrible triad of Hotchkiss. So that's a terrible triad of elbow. Here comes another elbow question. A counter brace is used in. Okay, so this is testing your knowledge about elective orthopedic topics like, tennis elbow and common degenerative and overuse and abuse syndromes. The management of tennis elbow involves, number one, usually we give NSAIDs and ask the patient to do rest, right? The common wrist brace were used to manage the tennis elbow. But what other thing can be done, right? There is something called counter force brace. Why tennis? What is the pathology behind tennis elbow? The pathology behind tennis elbow is the extensor origin is being pulled, and so especially the extensor carpi radialis brevis. So that itself is a question: which tendon is most commonly affected in tennis elbow? So the answer is extensor carpi radialis brevis, and the next common tendon is extensor digitorum communis. So these two tendons are most commonly pulled. In that case, there is this mechanism, like if you try to brace this region and prevent the force which is exerting from the distal to hit the proximal, right, then you can give some rest to the proximal origin. So that's the philosophy behind the counter force brace. You're countering the force originating at the distal side. That's what called as a counter force brace. So this is usually this concept is used in tennis elbow, but it's not really helpful. Although theoretically it seems to be helpful, but in practical management, I don't think this is of great help, except in very few patients when the tear is very small. So my management would go NSAIDs plus rest with a wrist splint, and then if it is not reducing, then I would go for a steroid shot or a PRP injection. I can do like 3 PRP injections, and despite all my effort, if it is not working, then I will put the patient for surgery. So that's my way of approaching a tennis elbow. NSAIDs and rest for 6 weeks. If it's not working, PRP for 3 times. After 3 months of exhaustive non-operative management, if it's not helping, then I would go for surgery. Coming on to scoliosis, this is another potential topic. So this question asks about the scoliosis screening in school children, usually done in grade 5 to grade 8 students. And the picture is very important, guys. You look, the sex of the person is female, right? And the age is adolescent. So what am I trying to show with this picture is scoliosis. The most common type of scoliosis is adolescent idiopathic scoliosis. So the age group is adolescent, and the most common sex to be affected is female. So that's a potential MCQ point covered there. And the age group in which the school screening happening for scoliosis is grade 5 to 8, usually done by the PTE teacher or the school teacher, someone. And what's the simple test that you can do is Adam test. What is Adam test? You ask the patient to bend, and when a person bend, the normal alignment should look like that. But if there is any rib bump or a rib hump, then that's abnormal, and that patients need diagnostic assessment for scoliosis. So this is a easy screening tool. So what you are going to ask the students to do, just forward bending, right? So that's called as a forward bending test. So the correct answer is Adam test, forward bending. And The next question is about the scoliosis brace. See, there is a pattern, right? For in INI-CET, they are just choosing one topic and asking a different question from the same stem, right? So when you are preparing, that's the key. That's how you should study as well, right? So now for this question, the brace shown. So this was the brace asked, right? The brace was a Milwaukee brace. So the brace is Milwaukee brace. But how Boston brace look? That's how a Boston brace would look. What is a Taylor's brace? Taylor's brace is more like a soft brace and it supports just the spinal column, very commonly used in case of an osteoporotic fracture or a spinal fracture in order to give some kind of stability. So that's a Taylor's brace, and ash brace is this one. Okay, so ash brace is just to give some hyperextension at the spine. Okay, to produce some hyperextension at the spine. That's ash brace. A 10-year-old boy present with pain around the left knee joint on x-ray. There is a lesion at the distal femur extending up to the terminal end. The cross exam. Oh, come on. Just by looking into any of this picture, the answer is osteosarcoma. You don't even need to read the question. Any of this picture. I think the potential picture given in the examination was this one. But irrespective of whatever the type of picture, it is very easy diagnosis. Osteosarcoma. Most of the time, the question will literally beg you for the answer. Osteosarcoma. Okay, but what are all the points in this question which is actually begging you for osteosarcoma? 10-year-old boy, osteosarcoma is very common in the first 2 decades. So 10-year-old boy, that's the first clue there. And around the left knee joint, distal femur and proximal tibia are the two most common site for an osteosarcoma. And lesion at the distal femur, so you know it is telling more of an osteosarcoma, and the gross image of the condition is given. So that's the gross image, right? So everything, and in the gross image you can see there is a periosteal elevation there is some new bone formation there is an area of necrosis there, and the tumor is looking anaplastic or looking de-differentiated. So this is an osteosarcoma. Literally the question is begging you for the answer, and you know the x-ray findings, the periosteal elevation and the sunburst appearance. And look, it is a metaphyseal tumor, so it involves classically the metaphysis. The epiphysis is paired. Can you guys see that? The epiphysis is paired in there, in that cross image. So it's a metaphyseal tumor. Now let's read about an epiphyseal tumor. So this question, I would say osteoclastoma is something like it's something like a hall ticket for an examination. For any central board examination in orthopedics, they would always ask bone tumor and especially osteoclastoma. So this question is about osteoclastoma. The radiograph of the wrist is given below. Identify the true statement regarding this condition. True statement, of course, it's an epiphyseal tumor. Okay, so that's the true statement. If that one question, if you want one answer to be right, then I would say 3. Let's see other options. The age of occurrence is 50 to 60 years. Usually it is 30 to 40 years. It is a fourth decade tumor. Okay, it is a fourth decade tumor, or third and fourth decade tumor, I would say. A ground glass appearance on x-ray is diagnostic. The ground glass appearance, the soap bubble appearance, whatever the appearance they are telling, none of those appearances are diagnostic for osteoclastoma or a giant cell tumor. See, the soap bubble appearance can be seen even in an aneurysmal bone cyst. It can be seen in several other tumors. So there are differential diagnoses for the ground glass appearance. A fibrous dysplasia can show a ground glass appearance, and so there are heaps of differential diagnoses. So you cannot say ground glass appearance is diagnostic. So that's a false statement. That's a false statement. 30% of the case undergo malignant transformation. No, very rarely it undergo malignant transformation. Maybe something close to 4 or 5%. But definitely 30% of the cases, that's a big number. But irrespective of 4 or 5%, whenever you are diagnosing a person with an osteoclastoma, invariably you have to take an x-ray of the chest to rule out a metastasis into the lung. Another question from osteoclastoma. So a 35-year-old man present with a knee pain, the x-ray of the knee joint, see 35, I told, right, it's usually a 30 to 40 disease. A knee pain, and patient is x-ray is given below, and it is an epiphyseal tumor. Yes, epiphyseal tumor. So that says it's an osteoclastoma or giant cell tumor. What is the probable diagnosis? That's an osteoclastoma. The answer is right there. So easy question. Coming on to some basic orthopedic questions, like from the basic science. Which of the following substances used for bone formation in the patient with non-union? And the option was PMMA, BMP, calcium phosphate, calcium sulfate. Come on, calcium sulfate has nothing to do here. Calcium phosphate. See, putting a calcium phosphate into the bone can act like a graft, or in one way maybe if you solidify all the crystals and created it like a strut graft or something like that, then it can just give conductive ability to the bone. The new bone can form over this calcium phosphate. So all these demineralized bone graft salts, everything can act like an osteoconductive material. What is osteoconductive? It just gives a physical support or a scaffold over which the new bone can be formed. So it's purely a physical concept. It's purely physics, right? But what is an osteoinduction? What is osteoinduction? You are giving some chemicals or growth factor or hormones or whatever there, which is going to stimulate the native osteoblast and the undifferentiated cell to induce a new bone formation. So that's what called as osteoinduction. So they are the chemical or the factors. Thus, it's chemical in nature. And what is osteogenesis? Osteogenesis means you are putting the cell as such which are having ability to produce a new bone. So which means your graft is having an osteoblast, osteoclast, and osteocyte, something like an autograft. Something like an autograft from your iliac crest and things like that. So that is osteogenesis. That's a biological principle. So which of the following substance is used for bone formation in a patient with non-union? PMMA is a bone cement. I won't say that as a graft in any way, except it can give some structural integrity. It is neither providing any scaffold for a new bone to go across them. So it is not having any conduction, induction, or genetic potential in it. So I would right away rule out that option. And calcium phosphate might give some conduction environment there, but not induction or genesis environment. So the answer now is bone morphogenic protein. Bone morphogenic protein is something like a transformation growth factor. The next question is about a 40-year-old man, and this was the image given. A 40-year-old man is suffering from increasing difficulty in bending forward with increasing stiffness of a spine and reduced chest movement. A CT was performed and shown below. The likely diagnosis is. So what's the likely diagnosis? So the options were ankylosing spondylitis, rheumatoid, reader, fluorosis. See, the question, 40-year-old man. So middle-aged man. Middle-age and men. Usually rheumatoid is a female disease. Of course, it is a middle age as well, but a rheumatoid is a female disease. And increasing difficulty in bending forward. Okay, so which means the lumbar spine and the sacroiliac joint are affected with this increasing stiffness of the spine. So again, they are telling more about the spine and reducing chest movement. So now everything says there is a sacroiliac involvement and there is a lumbar involvement and there is a chest involvement. So it is an ascending arthritis. Ascending arthritis in a middle-aged man, the answer is ankylosing spondylitis. Ankylosing spondylitis. If at all they want rheumatoid arthritis as an answer, then they would have given this picture to you, right? Because rheumatoid arthritis usually affects cervical spine, C-spine, than lumbar, thoracic, or sacroiliac joint. So I don't think they are expecting rheumatoid arthritis as an answer. Fluorosis usually cause, thickening of the longitudinal ligaments there, calcification and things like that. But it's very uncommon. And given reduced chest movement and stiffness of spine, I would think more of an ankylosing spondylitis than any of the other options. Now, the question is about osteoarthritis. A 72-year-old man came with the complaints of unilateral knee pain. See, unilateral knee pain. Okay, 72, old age. An X-ray exam shows reduced joint space, osteoarthritis. Pathological finding includes. So, they would have given you, they might have given you a histological image of an osteoarthritis. Let me teach you how would an osteoarthritis pathological slide would look when compared to the normal. See, that's a hyaline cartilage, right? That's how an hyaline cartilage should look, with a clean surface. If you go read Guyton, If you go and read Guyton, in Guyton they would use a word. A cartilage, rubbing on a cartilage, is something like a glass gliding on a glass with one drop of water in between them. It's so frictionless. It's so friction free. Okay. But when it goes for the degeneration, all this surface goes for brittling, breaks, right? So whenever there is this surface damage, and then there will be a lot of water collecting in there, and it's 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 more of a wet cartilage lesion with a lot of surface damage. So that's how an osteoarthritis cartilage would look compared to that of a normal cartilage. So the answer for this, even without looking into the image, you can say it's an osteoarthritis. But if it is a tuberculosis of the knee, then you would be looking into the caseation and the epithelioid cells. If they are giving you an rheumatoid arthritis, then they would be showing about the pannus, and the pannus would have like a fibrous growth, and there is a neurovascular structure in between in it, and Lyme's disease would show you organism. So the next question is again from orthopedic tumor, and they ask for the management. Okay, let's try to match the disease with the management. Osteosarcoma, just think. For an osteosarcoma, will I do an intralesional steroid? No way. So if some option says 1 for D, then I'm going to strike the option out. So this is gone, that's gone. No way. Steroids? No way. Simple bone cyst. Can I do simple intralesional steroid for simple bone cyst? Because it's usually self-limiting. If at all it is not, then you can give a steroid, right? So I think I can consider an intralesional steroid. So 2, I can think of D. So that makes C as an answer. Giant cell tumor. Giant cell tumor, what? I extended curettage I would do. Osteoid osteoma, I would do a radio frequency ablation. So a giant cell tumor, I would do an extended curettage. Extended curettage. Osteosarcoma, I can do a wide excision. So the answer is 1A, 2D, 3B, and 4C. So if you see in this slide, whenever there is a tumor, you just get inside the tumor and debulk the tumor. That is called as an intralesional excision. You can do that for a simple bone cyst. And then fill the area with a steroid, right? Or a bone graft. That's fine. You can do that for a simple bone cyst. What is a marginal resection? Marginal resection is you are trying to take the tumor as a whole, but you are not taking any of the soft tissue around it. Thereby, there is a high chance for you to leave a macroscopic deposits around in the soft tissue. Maybe you can do these for benign conditions, with the periosteum you can take for an osteochondroma, right? It's a marginal excision. You are extra periosteal excision of tumor. So you are not taking any soft tissue around. Okay, so that's an example for marginal. What is wide excision? You are taking some tissues around like 5 centimeter, of soft tissue around the tumor. That is what called as a wide excision, usually done for malignant tumors. But remember, wide excision can take a macroscopic deposit, can take a microscopic deposit around the lesion, but it cannot address the satellite lesion anywhere in the same compartment, right? In order to get rid of the satellitic lesion, then you need to do what is called as an radial excision, which usually is an amputation. Like you're taking like one whole compartment, and usually it end up in an amputation, right? So that is what called as a radical excision. So osteosarcoma, usually you do wide extended excision, but still you will assess for satellite lesion, and if there is a satellite lesion, then you may need to consider sometime a radical excision. A 65-year-old postmenopausal female patient comes with a persistent backache not responding to conservative treatment. 65, back pain and not responding to conservative treatment. 65, oh, that's a red flag that you need to assess. You need to think of investigating this patient. She has a history of lifting heavy weights for 4 months back and progressively increasing pain that worsens on walking. So now they are giving you a history. This is a back pain, and that is not related to an infection. The patient is not having fever or things like that. So now I'm getting slightly narrowing down my differential diagnosis, and they are telling lifting heavy weight and then back pain. So I should think more like a disc prolapse and things of that sort. So the option now I'm thinking is lumbar stenosis, but still the pain starts radiating down her leg. Again, it's telling me more of like a lumbar stenosis. After walking for a distance around 100 meter, when they are giving this pain, 100 meter, the patient is feeling pain. That reminds me of claudication. So now the question is whether this is a vascular claudication or a neurological claudication. So that's the question is about. However, she feels no pain on walking uphill. Remember, vascular claudication will cause more pain on walking uphill. So this is not a vascular claudication, rather this is a neurological claudication. So the most probable diagnosis for this is lumbar stenosis. And come on guys, thromboangiitis obliterans, that is happens in a male predominant and in a middle age, and the patient because of smoking. So all these are buzzwords to say this is a thromboangiitis obliterans, right? So definitely C is not the answer. So the answer is B there. And the next question is about another sign, something like a Thomas sign. This is another commonly tested sign called Trendelenburg sign. Okay, Trendelenburg test basically assess abductors, hip abductors, that is gluteus medius and minimus. It assesses hip abductor, but the word hip abductor doesn't mean that just the muscle. I mean the whole of the abduction mechanism. If there is a stenosis at the lumbar level which is supplying the gluteus medius and the minimus, then you can still have a Trendelenburg sign positive. If there is a damage to a superior gluteal nerve, which is the nerve supply of the gluteus medius and minimus, then still you can have a Trendelenburg positive. If there is an injury to gluteus medius and minimus, or the muscle has gone for necrosis or stretching or contraction or whatever it is, you can still have a Trendelenburg sign positive. Or the insertion of gluteus medius and minimus into the GT, greater trochanter, if that is injured, then you can still have a Trendelenburg sign positive. If there is an intertrochanteric fracture, Trendelenburg sign positive. If there is a neck or femur fracture, Trendelenburg sign positive. If there is a femoral dislocation, Trendelenburg sign positive. So the entire abductor mechanism has to be intact for the person to not to stay normal when you are doing that Trendelenburg test. So it involves from the spine to the superior gluteal nerve to the abductor muscle to the greater trochanter insertion to the intertrochanteric region and the neck of femur and the hip joint. Everything has to be intact for the entire abductor mechanism to act normal. Otherwise, the patient will go for Trendelenburg sign positive. What is Trendelenburg sign positive? If you ask the person to stand with the affected limb, the opposite hip would dip down. The opposite hip. So which abductors are being tested? The abductors of the standing limb is being tested. The abductor of the standing limb is being tested. Okay, so whichever the side the pelvis is tilting or dropping, the opposite side abductors are being tested. Okay, so just remember which side is being tested and which muscle group is being tested, and things like that. And positive sign is dipping of the pelvis in the opposite side. Okay, so positive sign is not good. A Trendelenburg sign positive is bad, and it assesses the hip abductor mechanism. So the answer for this is A. You visit a newborn near your house and notice that the baby has CTEV. Come on, okay. So when would you advise the patient's parent to go for consultation to put on a cast as early as possible, right? As SAP. So within few days you should go and visit, right? Because the early you start, the better is the prognosis. And the first thing that you would correct is cavus, and the next thing you would correct is adduction, and the next thing you correct is varus. Varus is version, which is the inversion, supination, and varus, and then at last you will correct the equinus. And if the equinus is not correctable with just molding, then you may need a tenotomy, Achilles tenotomy. So that's my way to go, and it should start as early as possible. So my answer is in a few days. Again, another question from CTEV, right? So the combination of appearance in CTEV, all patient is having equinus, and I told what you have to correct, right? Forefoot adduction is next to correct. So forefoot abduction is a wrong answer. So forefoot adduction is the right answer. And I told inversion, supination, and varus has to be corrected. So which means eversion is the wrong answer, right? And the deformity is cavus. You all know CTEV is a cavus condition. So planus is definitely, planus is normal. Like, so this is not the right answer. So the answer is equinus, inversion, forefoot adduction, and cavus. Another question from trauma, which is a road traffic accident. A patient developed a type 3 compound tibial fracture, 3A, Costello-Anderson 3A. You have to put this patient on external fixator. Arrange the following external fixator in decreasing order of their stability. 3A, sometime, you can sometime wash, and now most of the time I better prefer an external fixator for this condition. So if at all you are putting an external fixator, which is the most stable. So they are giving a Lizaro and uniplanar with just a single rod, uniplanar with a double rod, biplanar frame. That means one rod in x-axis and another rod in y-axis, like in two axes you are putting. So that is, which of this is more stable? The ring is always more stable than everything. So I would say one is the most stable structure. So either the answer could either be A or C, right? And the next thing would be a biplanar would be the next better construct than the uniplanar. So answer is C. 1, then comes 4, then comes 3, and then comes 2. So the order is 1, 4, 3, 2. So the option C is the correct answer. Another open fracture question. Following a femoral shaft fracture, your consultant, it's not an open fracture, okay. So it's usually in public hospital when the waiting hours for the fracture is too long, you need to keep the fracture immobilized in case of like a femur fracture where you cannot put the patient on Thomas splint for like ages, like for a week or two. In that case, what would you do? You may need to provide a skeletal traction, and the question asks about what are all the things that you need to do the skeletal traction in case of fracture of femur. So the splint they are assessing you is the BB splint, right? So you need the BB splint, and in order to put the BB splint into the bone, you need the Bowler stirrup, and this Bowler stirrups goes to the Steinman pin. Why not Denham pins? Denham pins are usually for calcaneal traction, and calcaneal traction you would do that for a tibial fracture. So when the fracture is here, you can put a calcaneal pin, but when the fracture is here, you need to do a tibial pin, and in tibial pin, Steinman pin is much better option than a Denham pin. So you need a Steinman pin, you need a Bowler stirrup, and then you need some weight, and all this goes in a Bowler bone. So 1, 2, 3. So I would say 3, 5, and 6 are what I need. So that's the correct answer. Coming on to what is not required on emergency basis in an open fracture. Close reduction, internal fixation, splinting, antibiotic coverage. Come on guys, open fracture. Open fracture, do I need antibiotic coverage? 100%, because it's infectious. A lot of infection from the site would have entered into the circulation and into the fracture site. So it's better you give an antibiotic coverage. Do you need to immobilize it with a splinting? It can be it could be an external splinting, as in case of an external fixator. Yes, I need it. Do I need a close reduction? Yes, I need to try reducing the fracture before applying the splint. So I need 1, I need 3, I need 4. So the question asked is which you do not require. I do not require an internal fixation as a first step when it comes to an open fracture management. If it is a grade 1, if it is a grade 1 or 2, then I may think an internal fixation as well. But the first 3 things I would consider would be a close reduction, splinting, and antibiotic coverage. So if at all they need one option in this, then I would say internal fixation is the least thing that I would think about when there is a open fracture. The next question is about the same external fixator, but this time the complication of external fixator. Since the external fixator is something what is going from outside, there is a high chance for an infection as well. So this we called as a pin site infection, and whenever there is such pin site infection happens, it can cause a typical sequestrum called as a ring sequestrum. So ring sequestrum is seen in pin tract infection, which is due to an external fixator, which is due to external fixator. So what are the other type of sequestrum? How are sequestrum classified based on shapes? A tubular sequestrum can be due to pyogenic infection, and ring sequestrum due to external fixator, pin site, and black sequestrum, the color sequestrum, are due to fungal infection, and the coralliform sequestrum due to Perthes, and coke raised grain sequestrum is due to tuberculosis. Sandy sequestrum, or again raised grain sequestrum, is tuberculosis, and feathery sequestrum is seen in syphilis. The next question, oh, don't think it's tumor. It's definitely not tumor. The question say something about ALP level. So let's read the question. The child present with a poor growth and swelling at the joints. Poor growth, okay. And radiograph of the wrist is given below. The lab investigation reveals serum alkaline phosphatase more than 1500. What is the possible diagnosis? Poor growth, wrist widened wrist, poor growth in a child, it is rickets. Okay, irrespective of type of rickets, whether it is a nutritional rickets, so vitamin D resistant rickets, or vitamin D dependent rickets, or X-linked dominant rickets, or whatever the type of rickets, irrespective of type of rickets, alkaline phosphatase is always elevated. That is like a good marker to say that this child is having rickets. So the answer is rickets. And in case of scurvy, you will be seeing the white line. It is not the typical fraying, cupping appearance as in this x-ray. You will see like a white line there, Wimberger sign and things like that. That is not seen. So this is not scurvy. Osteogenesis imperfecta, you will see multiple fracture in case of an osteogenesis imperfecta. And Paget's disease is definitely not a child disease, especially not a child of this age. Okay. See, osteoporosis, the diagnostic test is a DEXA scan. Okay. By lab investigation, it is very, very hard for you to diagnose osteoporosis, because osteoporosis is a bone mass problem. It is not a mineralization problem. Okay, it is not a mineralization problem. You see, this is a normal bone mass and the normal minerals, right? But if you take an osteoporosis, the bone mass as such is reduced, but the proportion of minerals to the reduced bone mass is still normal. So if you provide the additional bone mass, then the patient would develop the minerals for this additional bone mass. And that's why the treatment of osteoporosis is bisphosphonates. It's not just calcium and vitamin D, right? The treatment is bisphosphonates. But what is osteomalacia? Osteomalacia is not a problem of a bone mass, rather the problem of the minerals. The proportion of minerals in this, you see the yellow, that's the minerals. But here the yellow amount is reduced, right? But the red amount is increased, which means that the non-mineralized, the unmineralized matrix is more compared to the mineralized matrix. So that's osteomalacia. That's why a vitamin D and calcium supplementation can help osteomalacia, but not osteoporosis. So when a patient is presenting to you with an osteoporosis or features of osteoporosis, do a DEXA scan, diagnose osteoporosis, and supplement them with the bisphosphonates, not just with vitamin D and calcium. Okay, you will give the patient vitamin D and calcium along with bisphosphonates, but not just vitamin D and calcium for osteoporosis. And what is the most specific test for carpal tunnel syndrome? So this is Fallon test, and that is Tinel sign and 2-point discrimination. This is apparatus to assess the 2-point discrimination. Okay, but among this, which is the most specific test? Durkheim test. Durkheim test is the most specific test. What is Durkheim test? Just compression into the carpal tunnel. For some time can cause a pain and tingling sensation in the median nerve distribution of the hand. That is what called as a Durkheim test, and that is the most specific test. But 5 years back or 3 years back, when the question about carpal tunnel syndrome test was asked, the Durkheim test was not an option, then the answer is Phelan test. Okay, so the best answer is A. If the option Durkheim test is not there, then the second best option is B. Okay, tunnel and 2-point discrimination is not a very specific test when it comes to carpal tunnel. So this question is about a nerve sheath, nerve fiber, and the nerve injuries, right? So the question asks, if the outer sheath and the nerve fiber is intact, the outer sheath is intact and the nerve fiber is intact. If the nerve fiber itself is like completely cut along with the outer sheath, then it is neurotemesis. But they said the outer sheath and nerve fiber is intact, which means it is not neurotemesis. And the inner axons are damaged. If they say the outer sheath, nerve fiber, everything is intact, along with the axon, everything is intact, but still the nerve is not functioning, that is neuropraxia. Everything is intact. There is no anatomical discontinuity, but still the nerve is not functional, which means physiological problem, but not anatomical problem. Then you can think of neuropraxia. But here they said the inner axon are damaged, which means it is not neuropraxia. What is the diagnosis? The diagnosis, axonotemesis. Axonopraxia is just a filler word to make this question up, but the answer for this is axonotemesis. What nerve injury causes the given condition? Yes, this is a very tricky question. This is not a video. This is just a picture. If the test says that I ask the person to flex the fingers and then the patient showed this sign, which means the little and the ring fingers are flexing, but these two fingers are not flexing. So this sign is a benediction sign, and that answer is median now. Rather, if the question says the patient is coming to you and just showing the hand, and the hand is already showing like a clawing these two fingers, but the rest of the two fingers are functioning normal. This is normal, this is clawed. Then the answer is ulnar now. Given the question, which is straightforward, asking the picture, this is the picture, the patient, and what is your diagnosis? I would slightly think ulnar nerve clawing. But if the same picture is given with an explanation like the patient is asked to flex the finger and then the patient is showing this sign, then I would think of median nerve. But with no descriptions, just the image, if they are asking me to diagnose this, then I would slightly think more of ulnar nerve damage than a median nerve damage. This is another question assessing the nerve function as well. A book test is used to assess the function of adductor pollicis. Can you see? They are giving a card and they are asking the person to hold, and the person is holding it by using the adductor pollicis because they are adducting the thumb with the index finger there and adducting. Okay, which of the following nerve supplies this muscle? Adductor pollicis. This is a book test or a card test, right? So instead of using an adductor pollicis, if he is flexing and holding the paper, then his median nerve is functioning, because flexor pollicis longus is supplied by median nerve, but adductor pollicis longus is supplied by ulnar nerve. So basically book test is assessing which nerve? Ulnar nerve. Ulnar nerve. Assessing ulnar nerve. Another card test. Again, this is assessing the adduction in between the fingers. Adduction in between the finger is caused by palmar interosseous. Palmar interosseous. You know why adductor ulnar nerve is called as a musician nerve? Out of 20 intrinsic muscles at hand, 20 intrinsic muscles of hand, 15 are supplied by ulnar nerve. Or I should say 15 and a half is supplied by ulnar nerve. Only 4 and a half is supplied by median nerve. Okay, in that case, ulnar nerve supplies maximum like 4 interosseous, dorsal interosseous, 4 palmar interosseous, and all hypothenar muscles and lumbricals, like 2 of lumbricals, and heaps of muscles are supplied by ulnar nerve. So ulnar nerve is called as a musician nerve, and palmar interosseous causes adduction in between the finger. And dorsal intrachea causes abduction, fanning of fingers. So palmar intrachea is again supplied by ulnar nerve, and that is assessed in this test. So inability to adduct the finger is what tested. So ulnar nerve function. Okay, and the question also gives several clue to say it is an ulnar nerve problem. Okay, and thus the patient is having inability to adduct the finger. Okay, so what are all the other clues in the same question? A 6-year-old girl sustained a fracture of lateral condyle humerus, which led to develop an elbow deformity. So what the question they are asking? Fracture of lateral condyle can lead to what complication? Cubitus valgus, right? And that's what explained in the next statement. Led to the development of elbow deformity, cubitus valgus. And cubitus valgus can lead to what complication? Cubitus valgus can lead to what is called as tardy ulnar nerve palsy. And tardy ulnar palsy manifests as inability to adduct the finger, because ulnar nerve is the one which supplies the palmar intrachea, and palmar intrachea are adductors of the fingers. So that's what is tested. If you are interested to learn more, if you want me to do more on INI-CET kind of topics, please comment below. Thereby I can make a separate video. Thank you and good luck for your examination. Let me know how you did your exam.